Remember that 60% of this slope is tendon attachment. The deeper portion is the RCL ligament, the radial collateral ligament. This is a near full thickness tear with calcification of the deeper radial collateral ligament. So again, make sure you evaluate those interfaces closely, remembering it's a ligament deep and a tendon superficial. Wrist and hand pathology. Here we have on the dorsum of the hand and wrist a dorsal ganglion. The bony margin here is the scaphoid. This is the lunate in between here, and this well-described, well-circumscribed anechoic zone here, which is non-compressible with propressor, is a dorsal ganglion. You may or may not find some Doppler signal in here. Go ahead and turn on the Doppler and see if you can. Usually not. But your telltale sign for a dorsal ganglion is obviously because it's so visible, but it's also a non-compressible cyst. Dorsal rest tendinosis, again, the hypoechogenicity and fluid within the tendon sheath, kind of a rare thing. But some of this is also considered to be edge artifact, but that is excess fluid surrounding that extensor tendon in short axis. Here's the same area of fluid and poor fiber echogenicity here in the long axis. Dacre veins, we talked about this also in the hand and wrist. The extensor pollicis brevis and abductor pollicis longus both occupy what's typically called the same tendon sheath. In reality, there is no tendon sheath that encloses these two tendons. They are actually entrapped by the extensor retinaculum. So it should, in reality, we could call it retinaculitis, but instead of tenosynovitis. But just so we can understand that it's not really a tendon sheath problem, but a retinacular constriction, and that can cause